All right, let's jump right in. We are skipping the introductory fluff today to execute a highly polished, high-stakes clinical explainer. We're targeting perfect USMLE scores. What you're looking at is an integrative drill focusing on severe acute pancreatitis management. We're going to strictly detail the intricate mechanisms, the discrete management steps, and the precise clinical markers you absolutely must recognize to dominate this material. So, let's lock in the absolute baseline right out of the gate. For acute pancreatitis, the diagnosis strictly mandates that lipase or amylase is elevated to greater than 3 times the upper limit of normal. 3 times. Keep in mind, lipase, it's generally way more sensitive and specific than amylase. If you don't see that strict 3 times elevation, you've got to start hunting for other corroborating data.
This brings us to the 2 of 3 diagnostic mandate. Clinical pathways strictly require confirming exactly 2 of these 3 absolute parameters. First up, that characteristic severe epigastric pain that classically radiates straight to the back. You know, the kind that often improves when the patient sits up and leans forward. Second, the lipase or amylase elevation we just talked about, greater than 3 times the normal limit. And third, cross-sectional imaging confirmation. We're talking ultrasound or a contrast-enhanced CT showing an enlarged pancreas, peripancreatic fluid, or fat stranding. Remember, you strictly need 2 out of 3. Please, do not demand a CT scan if the clinical and lab criteria are already met.
Now we need to drill the exact thresholds where mild presentations suddenly cross over into severe, life-threatening metabolic derangements. We use scoring systems like Ranson criteria or Apache 2 to gauge severity, right? They map demographic and lab data to predict mortality. The absolute key here is recognizing the exact moment a patient shifts from localized pancreatic inflammation to full-blown systemic shock.
Let's move on to early aggressive fluid protocols. Historically, the medical field used to routinely starve these patients and reflexively reach for normal saline. But, well, the data has shifted dramatically. Lactated ringers is now the absolute crystalloid of choice. Why? Because high-yield literature demonstrates it definitively reduces systemic inflammatory response syndrome, or SIRS. Even uncomplicated patients without hypotensive shock still absolutely require this early aggressive fluid resuscitation to prevent necrosis.
You need to track these lethal risk markers intensely. Out of all the laboratory values you're going to monitor, an elevated blood urea nitrogen, or BUN, is the single most reliable indicator of mortality in acute pancreatitis, period. A rising hematocrit is another massive red flag. It indicates severe hemoconcentration and third spacing of fluids. Throw obesity into the mix, and you further compound that mortality risk. So what's the crucial takeaway? BUN must trend downward with appropriate fluid management. If it doesn't, your resuscitation is failing. Notice the clinical variance regarding fluid tolerance here. Aggressive fluid management mandates actually shift dynamically based solely on patient tolerance and BUN normalization during those critical initial 24 hours. You've got to constantly assess the metabolic response. Give too little fluid, the pancreas necrosis from hypoperfusion. Give too much, you precipitate volume overload, which is especially dangerous in patients with comorbidities. Transitioning over to a major nutritional paradigm shift, we need to define the enteral mandate. In severe or critically ill necrotizing cases, placing a nasogastric or nasojejunal tube and initiating enteral nutrition within 24 to 48 hours is absolute. That is, once the patient is hemodynamically stabilized, of course. The old days of waiting days and days to feed these patients, those are over. Let's contrast the barrier function with the parenteral contraindication. Why is enteral feeding so incredibly critical? Because it strictly maintains gut barrier function. Enteral feeding prevents mucosal atrophy and halts bacterial translocation from the gut. And remember, bacterial translocation is the primary driver of infected pancreatic necrosis. Conversely, total parenteral nutrition, or TPN, is strictly a last resort. It bypasses the gut entirely, promotes mucosal breakdown, and massively increases the risk of lethal line-associated sepsis. We have another clinical variance to discuss: enteral versus oral feeding. Our nutritional strategy splits based on severity. Mild presentations actually allow for early oral feeding with a low-fat diet, right as soon as the patient has an appetite and their pain is controlled. But severe necrosis strictly mandates tube-based enteral delivery. The fat content is kept low so we don't stimulate the pancreas, but early introduction of nutrients is absolutely non-negotiable for protecting that gut mucosa. Okay, let's map out the 4-week necrosis wall timeline. This is where your clinical discipline is truly tested. Days 1 through 7 represent acute inflammation. During this window,
Prophylactic antibiotics are strictly contraindicated for sterile necrosis. Days 7 to 21 require ongoing monitoring with the strict delay of any surgical intervention. Then, by week 4 and beyond, we see the maturation of what we call walled-off necrosis, or WON. Let me emphasize this. Premature, invasive intervention before this wall forms carries a massive risk of catastrophic hemorrhage.
Navigating this sterile versus infected cross involves very exact management steps. You must enforce the rule that prophylactic antibiotics are strictly contraindicated, even when you're staring down severe sterile necrosis. Step 1. Identify clinical deterioration. This usually presents as a new fever or worsening leukocytosis several days after initial presentation. Step 2. Obtain a CT scan with IV contrast to assess the necrosis. Step 3. Withhold antibiotics until you have absolute confirmation. And Step 4. Target therapy with carbapenems thanks to their excellent pancreatic penetration, but only upon confirmed infection.
This brings us to a crucial clinical variance regarding necrosectomy timing. We must enforce the absolute delay of this procedure. Surgical debridement is strictly withheld until encapsulation is confirmed. That means waiting greater than 4 weeks post-presentation. If you go in early, you risk massive bleeding and spreading the infection. You must wait strictly for the collection to wall off before proceeding with invasive debridement. Now, we're going to integrate these complex matrices into a high-stakes master case blueprint to really test your clinical discipline. Consider this scenario. You've got a 45-year-old patient on day 3 of a severe alcoholic pancreatitis admission. A CT scan shows 50% pancreatic necrosis. The patient is currently NPO, meaning nothing by mouth, and is receiving IV fluids and analgesics. Here is the diagnostic trap. On day 4, during a clinical status check, the patient develops a new fever and a rapidly rising white blood cell count. This is specifically designed to lure you into premature, potentially fatal interventions. You see a fever, you see 50% necrosis, and your instinct screams infection. But remember the timeline we just mapped out. Let's confront this rigid 5-option matrix, simulating actual exam conditions. The prompt demands the single most appropriate next step for long-term survival. Here are your options. A. Imipenem therapy. B. Immediate surgical debridement. C. Enteral nutrition via nasovaginal tube. D. Total parenteral nutrition, or TPN. E. CT-guided percutaneous drainage. What's your move? Let's forcefully dissect each option to prove the correct mandate. Initiating enteral nutrition, option C, is the absolute correct answer here. Why? Because early enteral feeding prevents the bacterial translocation that causes infected necrosis in the first place, ultimately securing long-term survival. We forcefully bypass option A, initiating premature prophylactic antibiotics for a day 4 fever without CT confirmation of infection is strictly contraindicated. Option B, early surgery, that would lead to catastrophic hemorrhage. Option D, TPN, is contraindicated as it massively increases sepsis risk. And E is premature. You must treat the underlying physiopathology, not just the reactionary numbers. So ask yourself, in the heat of a crashing clinical presentation, will you treat the alarm or will you protect the systemic barrier? Master that distinction and you'll absolutely master the drill.